Hi there, welcome to my YouTube channel and our ongoing discussions about psychiatric disorders. In this episode we'll be talking about the bipolar disorders, as there are several subtypes. And I think it's important to talk about this because it really is all over the news. It's probably one of the most talked about diagnoses nowadays. Oftentimes I've even heard it in movies and serials whereby somebody's pejoratively referred to as bipolar or having mood swings as if they are bipolar. That's unfortunate actually, because this is a very serious disorder that's been described going all the way back to the 19th century actually. And I'd like to take this opportunity to really educate people about what it actually looks like. It's a very real disorder, it's very disabling. It's probably associated with a greater suicide burden than even the depressive disorders. It's certainly extremely disruptive for the individual, their family, and even in the workplace at times, of course, where you can imagine it spills over because the insight of the patient in the middle of such episodes can be quite impaired. I've seen patients and treated patients with this disorder both in the hospital and in the outpatient clinic. So I can tell you that this is a bona fide disorder that does exist and that has a specific set of treatments. So let's go through it. Obviously the term bipolar implies two poles, and actually that's relevant because it's a starting point for describing the two extremes, as it were, of bipolar disorder. So at the one extreme is what we call hypomanic or manic episodes. And so what they are discrete periods of either elevated or irritable mood that are associated with walking fast, talking fast, increased energy, drive, goals, movements, and sometimes decisions at which, when one looks back upon them, are very reckless and dangerous. Spending sprees, sexual indiscretions, etc. Now, to qualify for a manic episode, these have to be so serious that they will likely require hospitalization, and they'll come to the attention of law enforcement. So clearly the psychosocial functioning is very impaired. The DSM refers to the time period of at least 1 week in order to qualify for the diagnosis of a manic episode, which would actually define bipolar I disorder. And for a hypomanic episode, it talks about a lesser degree of mania without psychotic features for at least about 4 days. That doesn't mean that the functioning is not off, it's just not so severe as to require hospitalization, or is not affecting somebody's behaviors to a dangerous extent either to themselves or others. So those two poles, those two aspects of bipolar disorder are very important to keep in mind because they're episodic. They don't happen all the time. One may follow the other, and then there's a group of patients in between which psychiatrists are now realizing that kind of fall between the two poles. And this is where there's been some diagnostic confusion, because patients with these symptoms oftentimes have a mix of hypomanic, manic, and depressive symptoms. That's controversial, just to tell you at the outset, because it looks like a lot of other things. It could look like an agitated, anxious depression. After all, you're antsy, you want to get up, you find it hard to relax, you may do things because of anxiety that might look like hypomanic symptoms, but it takes a very careful history. And I think psychiatrists in practice are realizing that bipolar disorder, as classically described in the textbook, is not as simple as it was originally described. So those are the manifestations of bipolar I, bipolar II, and bipolar disorder with mixed features. Now there's a whole subset of associated features that the DSM has outlined, which can be confusing in my opinion, but essentially you could have anything from anxious features, what we call atypical features, melancholic features, seasonal features, and there's another category of what we call substance-induced mood disorders, whereby someone who's maybe depressed, who has started on an antidepressant, may become manic, and it results in their being re-diagnosed as bipolar disorder if those symptoms persist. Now, we're going to distinguish bipolar disorder and depressive symptoms, manic symptoms, from simply taking a drug. Like, if cocaine were ingested, one could look manic. If large amounts of marijuana were ingested or inhaled, they could look depressed. So one must be careful about distinguishing whether this is from the effects of a drug or it's the underlying disorder. Now, of course, no doubt, you can imagine that people who are either in a manic or even depressed phase of bipolar disorder may resort to substances in order to self-medicate. And again, the clinician will have to ask a series of careful questions to kind of tease out what started first, what started second, what caused what. So that can be hard. In teenagers, it's even harder. You may be interested to know that the diagnosis of bipolar disorder in teenagers over the course of the last 10 to 15 years was actually around 8,000% more in the United States than anywhere else in the world. And this is because the criteria were being imperfectly applied, according to what the DSM-5 iteration says, to patients who are persistently irritable, whereas the emphasis really should be on the fact that bipolar disorder presents with episodic mood changes. They don't last forever. They will typically go on for a number of days, possibly weeks, and then they may return to a baseline, or they may go back into the other pole, which is the opposite. And so that has its own discrete period of time. A number of children with persistent irritability were being diagnosed with bipolar disorder, and it was problematic because it was diagnostically confusing and arguably unhelpful. So the DSM actually created a separate mood disorder called disruptive mood regulation disorder for people under the age of 18, and specifically with kind of temper tantrums, persistent ones, starting under the age of 10. So those are the official diagnostic criteria. Let me tell you what I tend to see in clinic or in the hospital. It'll usually be very obvious if someone's hypomanic. I mean, the family will be the first to tell you. Sometimes when you ask the patient how they're doing, they'll just say, "I'm doing great." Reminds me of the Frosties advert. And obviously that's not a reliable history by the patient because they're subjectively wrapped up in the midst of it. It's family members who are actually very key in describing the change in someone's mood state over the course of days, possibly weeks, whereby they're looking more and more energized, for example. They're talking faster and faster. They're making more and more questionable decisions. They're on a roll. It's as if they've taken cocaine, but they haven't, typically. And so that discrete change will be noticed by family, and it will be reported by family. And of course, if it becomes extreme enough, it may come to the attention of law enforcement because people in such a state have a very fragile mood. So when we talk about mood swings, they have what we call mood lability. They can quickly go from a euphoric state right into an irritable one or an explosive one. So their moods are very fragile and labile. Now that's different to what the public calls as mood swings. Mood swings, from what I've surmised as a practitioner, the public is typically referring to irritability, where you are doing okay and you suddenly become irritated, as in the example of, say, someone cuts you up in traffic. So that's irritability, as opposed to mood lability, which is, again, kind of a minor, in-the-moment swing from a euphoric state, happy, joyous, zestful, to a very irritable and nasty, difficult to handle state for both the patient and others around them. And it can happen within a matter of minutes. And so you can tell how fragile their moods are. The other cardinal feature of bipolar disorder is decreased need for sleep. Now, again, depending on how a practitioner asks the patient about this, many patients say, "Oh, I don't sleep." That's not enough to diagnose bipolar disorder. What I need to know is, do they need to sleep? Do they want to sleep? And this is where it becomes particularly problematic for teenagers, for example. Because as you know, a lot of teenagers like staying up late and they're on the internet and they're on a roll, and you can see how it gets diagnostically quite confusing. Of course, if you don't sleep, you're likely to make your manic symptoms even worse, because sleep is a very necessary part of the recovery from manic symptoms. Oversleep, as we discussed in our previous video on major depressive disorder, can actually worsen depressed mood. People used to be sleep deprived in the early days of the 20th century to treat depressive disorder. But as you can see, in mania or hypomania, which is a milder version without psychosis or major disruption to your psychosocial functioning, you will find that they just don't miss sleep. And the funny part is, they don't even miss it the following day, which is unusual. Most people, if you don't sleep during the night, it's likely to kind of hit you later on in the day, particularly in the afternoon. You may get that morning burst of energy, which all of us do because of cortisol, which is a hormone that's released as part of your circadian rhythm, your biorhythm, but most people will be tired the next day. That's not true of mania. They are on a roll. And I have seen patients who've come in having been up for 3, 4, 5, 6, 7 days in a row. And you would imagine they'll be exhausted, but they are not. And they are missing the very thing that they need, which is sleep. So, when talking about the treatment of bipolar disorder, one wants to distinguish between the treatment of acute, severe bipolar disorder that typically ends up in a hospital and the treatment of milder bipolar II disorder, which is oftentimes mostly treated as an outpatient. Having worked as an inpatient psychiatrist, I found that the most urgent need when someone presented as manic and possibly even psychotic is to make sure that they are calmed with an acute agent. Now that can be what we call the atypical antipsychotics. People have probably heard of Seroquel, olanzapine, also known as Zyprexa, Geodon, also known as Ziprasidone. These atypical antipsychotics also have mood stabilizing properties. And in particular, some of them have sedative properties, which are essential, you can imagine, in the acute manic phase of bipolar disorder that was severe enough to get them hospitalized in the first place. So if they do end up sleeping, that's a good thing. And I know this because I've done it in the past, given them appropriate doses of these sedating, or in the old way we used to call tranquilizing, but it's the same kind of term, to be able to help them get to sleep and thereby restore their appropriate mood and functioning. After that, they have to be continued in the hospital, and as they calm down, maybe the dose can be gradually lowered. Now, there's obviously another class of agent used for bipolar disorder, and these are the mood stabilizers. However, they are not as useful in acute mania. Now, the exception would be a medication called Depakote, also known as valproic acid, where one can load it up, doing a certain calculation of milligrams per kilogram. You can kind of divide the dose into 2 doses and give what we call a loading dose, and that is likely to treat acute mania. It's not used as commonly as an approach nowadays in the hospital, but it is there. What you wouldn't do for acute mania necessarily is prescribe things like lithium, Lamictal, carbamazepine. These are long-term treatments to prevent the emergence of manic episodes and to stabilize the mood. So they're not so useful in the acute phase of treatment. They can be started while the patient is hospitalized, but once the patient is stabilized, in order for them to maintain their stable mood. And sometimes they require blood tests, etc. I won't go into that here, but suffice it to say, they are remarkably effective. Lithium in particular is a very old drug. It's been around since the 1950s. And it's got a bad rap recently because it has a reputation for maybe affecting kidney functioning. But I think from my experience and those of the guidelines, provided one doses it appropriately, educates the patient about hydration and taking it at the right dose without alcohol or other agents that can affect its level suddenly in the blood to make it toxic, actually it's a very, very effective drug for mania. And in fact, it's particularly successful to treat irritability. In fact, it has an indication for doing that all of its own. Sometimes we even use lithium to treat irritability as part of a personality disorder. Some personality disorders are much more irritable than others. They're not necessarily manic, but you can see lithium as a powerful indication for that symptom in particular. The other medications have their own reputations and are used appropriately for other types of bipolar disorder, such as Depakote, which is used for what we call rapid cycling, when you have more than 4 episodes a year of either mania or depressed episodes or hypomania, and it can hopefully decrease the frequency and the severity of those episodes. And from previous videos, you can probably remember we talked about our yardsticks of what improves bipolar disorder. And typically, you want to see a lessening of the intensity and the frequency of future episodes. To have a completely flat line is arguably unrealistic. However, if you can adequately dose, we talked about this before in my previous videos, adequately dose the mood stabilizer or the atypical antipsychotic / mood stabilizer, because they have both properties. You can actually lower the dose to the extent where they can function, where the mood bumps are the least bumpy. And I guess that is our aim, to get the patient to be as functional as possible without necessarily giving an unrealistic expectation of 0 symptoms. There are some patients who hover around the slightly hypomanic level, or the slightly what we call dysthymic, not quite depression level. And maybe that's as good as it gets. But when they compare how they used to be to how they are on existing regimens, and it takes time to tweak it here and there over time, and actually time is your friend in that sense, if it tells you the nature and the frequency of the cycle, they will tell you that they are functioning a lot better. So I'm hoping that this has helped you have a basic understanding of what bipolar disorder looks like and the basic treatment regimens, the array of treatments that we have in order to help people lead a functional life once more. I hope this is helpful, and I hope to see you again in the next video. Thanks very much, and stay healthy.